is Kara Severe. It's February 25th, 2019. This is for Nursing 2 for ASU CIRCE, and it's over esophageal atresia with a tracheoesophageal fistula. Atresia is the incomplete formation of the esophagus, and a fistula is the abnormal connection between the esophagus and the trachea. There's no definite cause, but it's associated with trisomies 18, 21, and 13. It's also associated with women that during the first trimester use decongestants that contain imidazoline, and it's linked to the increased risk for congenital fistulas in that. There are also causes of acquired fistulas that include iatrogenic injury, a blunt gest or neck trauma, prolonged mechanical ventilation if they have an endotracheal or tracheostomy tube, and excessive tube cuff pressure in patients that are ventilated for lung disease. Some things you might see in the infant are excessive oral secretions. They will drool a lot and have an excessive amount of mucus. They would choke upon feeding, so if they are breastfeeding or using a bottle, the baby will seem to choke and have difficulty keeping their airway. They also might have a significant respiratory distress that would result from it. They'll have a sibilant cough, so after delivery, the infant might have the cough, and that indicates tracheomalacia. They also might have an oral obstruction. If an oral tube is placed to suction the stomach, it'll become blocked about 10 to 11 centimeters from the infant's lips. A mother with a fetus that has the atresia might also have polyhydramnios, and it is in approximately 33% of mothers with a fetus that has the atresia and the fistula, and virtually 100% of mothers with the fetus having the atresia without the fistula. They also will look for the bacterial syndrome, and this is in about 25% of patients that have the atresia. If one of the anomalies from the bacterial syndrome are present, then they automatically have to check for all of them. And if 3 or more of them are present, then they are diagnosed with the bacterial syndrome. This acronym stands for the vertebral defects, anorectal malformations, cardiovascular defects, tracheoesophageal defects, renal anomalies, and limb deformities. In babies with the atresia, they should get samples as soon as they can to determine their baseline values. They would look at the CBC, electrolyte levels, venous gas concentrations, a BUN, serum creatinine, blood glucose, and serum calcium. They might also look at a prenatal ultrasound, and it might reveal the size of a gastric bubble, polyhydramnios, or the bacterial syndrome. They also might look at an echo. It shows in the early care of the infants that might have the atresia and clinical signs of cardiovascular disease. They might also look at a chest radiograph. And it is mandatory and should be performed as soon as possible if the atresia is suspected. The surgical repair is almost always done soon after birth. Both defects can be repaired at the same time. Anesthesia is given and the baby is in a deep sleep and pain-free. They'll make a cut on the right side of the chest between the ribs. The fistula between the esophagus and the windpipe is closed. The upper and the lower portions of the esophagus are sewn together unless they're too far apart, then only the fistula is repaired. A gastrostomy tube would be placed, and the child would have another surgery later to repair the esophagus. Sometimes the surgeon will wait 2 to 4 months before doing the surgery. And if he waits, it allows the baby to grow or if have the other problems treated. If the surgery is delayed, a G-tube would be placed through the abdominal wall into the stomach. Local anesthesia would be used so the baby doesn't feel the pain. At the same time the tube is placed, the doctor might widen the baby's esophagus with an instrument that's called a dilator, and this would actually help make future surgery easier. If the surgery is delayed, there would be plans for putting a tube through the mouth or the nose into the upper pouch to help with continuous suction of the pooled secretions, and the baby would be positioned in the 45-degree sitting position, and they would be giving prophylactic broad-spectrum antibiotics. If the surgery is delayed, there would be plans for putting a tube through the mouth or the nose into the upper pouch to help with continuous suction of the pooled secretions, and the baby would be positioned in the 45-degree sitting position, and they would be giving prophylactic broad-spectrum antibiotics like ampicillin or gentamicin. They also might have a gastrostomy. If there's no distal fistula present, then a gastrostomy would be used. In this case, the stomach is small and laparotomy is required. So the baby is ventilated with high pressure, and the gastrostomy might offer a route of decreased resistance, and it would cause the ventilation gases to flow through the distal fistula and out of the gastrostomy site. They also might have TEF ligation. In these cases, some things a nurse would do would be to ensure safe swallowing. They would keep suction equipment at the bedside and suction as needed. They would talk with the physician about ensuring proper nutrition and might even use a PEG tube. They would also help to prevent aspiration. Before feeding, they would check placement, and they could use tube markings, x-ray, pH of the fluid, and the color of the aspirate. If the physician orders, they could use several drops of blue or green food coloring in the tube feeding, and that would help indicate the aspiration. Also, you could test the glucose and the tracheobronchial secretions, and that could detect the aspiration of the feeding. You would elevate the bed 30 to 45 degrees while feeding the patient, and then keep them like that for 30 to 45 minutes after. You'd also want to help reduce anxiety. You'd allow the family or the caregiver to talk about any anxious feelings and you would explain all the activities and procedures, making sure to use non-medical terms and to talk slowly and stay calm. You could also help teach them relaxation techniques, deep breathing, positive visualization, and you'd want to do all of this in advance so that they have the time they need to fully understand. You would want to make sure and teach the parents of these patients that asthma, bronchitis, and pneumonia are common and might continue into adolescence. Esophageal dysmotility and GERD might actually persist throughout life. Adults with history of atresia or fistula report a good quality of life, but some have neurocognitive outcomes and the ones with severe associated anomalies. The survival rate in the healthy infants that undergo surgical repair are virtually 100%. In the group of infants that have comorbidities or are not fit enough for the early repair, have a survival rate of 80 to 95%.